Hi, I'm Warren Clements speaking to you on behalf of the Rheumatic Heart Disease Program. Acute rheumatic fever, or ARF, is an illness which follows a Group A streptococcal infection in some people. The joints, brain, skin, and heart can be affected and is usually seen in children and young adults. Rheumatic heart disease, or RHD, is the damage to the heart valves that remains usually after more than one episode of ARF. Recurrences of rheumatic fever can result in further damage to the heart and should be prevented. To prevent ARF recurrence and to avoid or minimize rheumatic heart disease, secondary prophylaxis is required to stop infections with Group A streptococcal bacteria. Secondary prophylaxis with penicillin, most commonly given as an intramuscular injection called Bicillin L-A, is the only strategy shown to be clinically effective, but only if it is given within every 28 days. To give it monthly or 80% of the time is not recommended, because every day past the 28 days leaves the patient at risk of another strep infection and another episode of ARF. Some patients who are at higher risk of recurrent ARF may be prescribed injections every 21 days. Now, this treatment is usually required for at least 10 years, sometimes even more. This can be stressful and inconvenient, and the injections can be very painful. So, if we want patients to come back for this regular, ongoing treatment, it is important to identify any hurdles the patients might experience and to develop strategies to overcome them. This video provides you with an overview of the different injection sites and techniques and presents a range of strategies that may help to minimize pain, stress, and inconvenience.
To understand why the injections are important, it is useful to know what is happening within the heart with rheumatic heart disease. This shows healthy blood flow through the different chambers of the heart. Blood flowing through healthy valves moves without restriction through the 4 chambers of the heart. There are 4 valves: the mitral valve between the left atrium and ventricle, the tricuspid valve between the right atrium and ventricle, the aortic valve, and the pulmonary valve. Each valve is made up of leaflets that separate fully to allow smooth blood flow and then close tightly together to prevent backflow. This ensures that the blood circulates in one direction. In some people, the body's autoimmune response to a Group A streptococcal or gas infection causes inflammation. This is ARF and can include inflammation of the heart, which is called carditis. The heart valves may also become inflamed, which causes stretching and thickening of the valve leaflets. When the carditis resolves, some valve leaflets may remain scarred, stiff and immobile, or stretched. This is rheumatic heart disease. The valves predominantly affected in RHD are those on the left side of the heart, the mitral and aortic valves. There are 2 conditions of the heart valves in RHD: regurgitation and stenosis. With valvular regurgitation, the stretched leaflets have not regained shape and therefore do not close completely. This causes blood to leak backwards. Regurgitation is also referred to as insufficiency or a leaky valve. With valvular stenosis, the stretched leaflets have remained thickened and stiff, and the opening is narrowed, reducing the amount of blood that can flow through. If the narrowing is mild, the overall functioning of the heart may not be reduced. However, in severe stenosis, blood can back up and pool in the chambers, preventing adequate blood flow through the body. Blood pooling in the chambers has a greater tendency to clot, increasing the risk of a stroke or pulmonary embolism. And valves that do not have smooth contours are more likely to become infected. Regurgitation usually happens early in the disease, stenosis later in the disease process. It is possible to have both stenosis and regurgitation in one or more heart valves at the same time. As valve damage progresses, the heart has to work harder to circulate the right amount of blood through the body. In severe cases, the heart muscle enlarges and thickens, thereby losing elasticity and efficiency. It is common for people with RHD to develop heart failure.
When a patient receives secondary prophylaxis on time, every time, it is the best safeguard against the recurrence of ARF. Regular treatment has also been shown to reverse early signs of heart valve damage. Even if there has not been any valvular damage demonstrated, secondary prophylaxis is still required to prevent further ARF. The most effective prophylaxis treatment is with a long-acting penicillin. The brand of injectable penicillin currently used in Australia is called Bicillin L-A. It is also referred to as benzathine penicillin G or BPG. Bicillin L-A comes in a preloaded 2.3 ml ready-to-inject syringe with a size 21 gauge needle. The LA refers to long-acting, and it is important to know that this product also comes in a non-long-acting form. In this video, from this point onwards, Bicillin L-A will be referred to as Bicillin. If you do not have access to the preloaded Bicillin or use a powdered form, follow the product information sheet. Bicillin injections can be given before the 21 or 28 day due date. It is important that the interval between injections does not exceed 21 or 28 days. The use of oral antibiotic prophylaxis is strongly discouraged. Treatment with oral antibiotics, which need to be taken twice a day, every day, for the duration of the treatment, is difficult to monitor. It is also thought that the oral penicillin is less effective than the injections in preventing ARF and should only be considered in the following instances. Oral penicillin should be reserved for patients who experience bleeding problems following injection, and oral erythromycin is indicated for people with a documented penicillin allergy. The correct intramuscular injection technique is important to ensure pain is minimised and drug absorption is maximised. Injection into anything other than muscle affects drug absorption and could cause injury. For example, an unintended subcutaneous injection is usually related to difficulty assessing the thickness of the subcutaneous fat layer. Injection into a nerve can result in motor or sensory complications. There are 4 main intramuscular injection sites. 1. Dorsogluteal, also referred to as the upper outer quadrant of the gluteus maximus. 2. Ventrogluteal in the gluteus medius muscle. 3. Vastus lateralis or the upper outer thigh muscle. And 4. Deltoid or upper arm muscle. The deltoid muscle is only for small volume injections, less than 2 mL, and is most commonly used for vaccinations. It is not recommended for Bicillin deliveries and is not discussed any further in this video. The choice of injection sites depends on the clinician's discretion and experience, the patient's preference, the patient's age and weight, and your workplace clinical practice policy. If you are unsure, discuss this with the people who support you in your practice. The dorsogluteal site, or upper outer quadrant of the buttock, is the recommended site in the 2nd edition of the Australian Rheumatic Heart Disease Guidelines. However, this site is contraindicated in infants and young children. Injections into the dorsogluteal muscle have been associated with sciatic nerve injury. Therefore, care must be taken to identify the site correctly. A number of health facilities are adopting policies contraindicating the use of this site unless there are no other sites available. The ventrogluteal or VG site is defined in nursing literature to be an option for IM injection delivery for volumes up to 4 to 5 mL. Research suggests that this site is being taught in many education facilities in recent years, although adoption into practice has been slow due to nurse mentors not being familiar with the VG injection site. Compared to the dorsogluteal site, the VG area contains a greater thickness of muscle. It has a narrower layer of fat. Injections into this site are less likely to be inadvertently deposited into subcutaneous or fat layer. The area is relatively free of large nerves and blood vessels, which reduces the potential for significant injury. The VG muscle is usually in a relaxed state, even in the anxious patient. It contains less nerve endings and may therefore be less painful. However, it may be hard to keep a child still in this position, and it may be difficult to locate landmarks for injection into larger people. The vastus lateralis, or outer middle third of the thigh, is often the site of choice for the IM injections of infants and young children. Here the muscle is well developed, even in infants, and there are no major blood vessels or nerves underlying it. Refer to your facility's guidelines or literature for details on general preparation of the patient and equipment for intramuscular injection. Injecting into a tense muscle is more painful, so encourage relaxation of the muscle. For all intramuscular sites, insert the needle at a 90-degree angle. Dorsogluteal injection method. Place the patient in a prone, face-down position, or lying on side. Some patients may prefer standing up. The correct injection site is the upper outer quadrant. This can be identified in two ways. 1. Divide the buttock into 4 quadrants. Select the outer quadrant and inject into this area. 2. Draw an imaginary diagonal line from the posterior superior iliac spine to the greater trochanter. In the middle of the line, go up and out. Ventrogluteal injection method. Place the patient ideally in a side-lying position. Use your right hand on the patient's left hip or left hand on right hip. With the palm of your hand, locate the greater trochanter of the femur. Place your index finger towards the front or anterior superior iliac spine and fan the middle finger as far along the iliac crest as you can reach. The thumb should always be pointed towards the front of the leg. The injection site is in the middle of the triangle between the middle and index fingers. Remove your fingers prior to inserting the needle. Vastus lateralis. Anterior lateral thigh injection method. Place the patient in a supine, on back, or sitting position. Place one hand on the patient's thigh against the greater trochanter, the other hand against the lateral femoral condyle near the knee. Visualize a rectangle between the hands across the anterior lateral thigh, where the long sides of the rectangle are formed by an imaginary line down the centre of the anterior thigh, and another along the side of the leg. The correct injection site is the middle third of the anterior lateral thigh.
As we've already established, irregular Bicillin injections are very important. It is essential that any problems experienced by the patient are identified and minimised. Health staff should identify whether pain is a concern for their patients and work with them to determine which of the following pain and stress reduction strategies are the most effective. Minimising pain and stress remains very important all through the treatment period, but it is in particular so for the very first injections. Take your time and promote a calm environment, especially with a new patient. Encourage pain relief such as paracetamol or ibuprofen, approximately 30 minutes prior to the injection. This may be taken prior to presenting to the clinic. Topical anesthetic can provide relief from the needle pain. For example, amla cream or patch may begin to numb the site within 15 minutes, but it needs at least 1 hour to provide adequate pain relief. The patient may prefer to put topical anesthetic on at home prior to presenting for injection. Distraction is important as this can reduce anxiety. Depending on age, patients may respond to a bubble blower, a picture book or poster, or the use of an electronic gadget such as an iPad or similar. You can also distract by asking about their sport and hobbies, or playing a video or music. Many patients experience a higher level of stress as soon as they sight the needle. Where possible, prepare the injection outside of view of the patient and cover the items. Bicillin needs to be stored in the fridge, but cold preparations can be more painful when injected. Immediately prior to injection, Bicillin can be removed from the fridge and safely warmed to room temperature by rolling the syringe between warm hands. When patients are comfortable with this and like to be part of the process, they may be able to do this themselves. Apply fairly strong pressure with your thumb right on the chosen site immediately prior to injection for approximately 30 seconds, as this can help numb the area. Applying an ice pack pre-injection also has a numbing effect. After selecting the site, immediately prior to injection, gently tap the area to stimulate the nerve endings and minimize pain when the needle is inserted. Some health practitioners use a local anesthetic, such as lignocaine, immediately before or with the Bicillin injection to reduce longer-term injection pain. However, mixing Bicillin with an anesthetic solution and decanting into a larger syringe poses an infection risk and is not recommended by the manufacturer Pfizer, as insufficient data is available to substantiate this practice. Encourage the patient to relax because injections into tense muscles are more painful than relaxed muscles and may bleed more easily. Allow alcohol from the swab to dry before inserting the needle. This prevents a sting when inserting the needle. Bicillin is a thick fluid. Injecting slowly, over 2 or 3 minutes, allows the solution to be dispersed into the muscle gently, which can have a positive effect on pain. Encourage gentle movement of muscle following injection, as this will help absorb the Bicillin and may shorten the period of deeper muscle pain. This can be achieved by applying slight pressure and gentle massage to the injection site with a flat hand and walking, cycling or other leg exercises. Use a cold pack application post-injection. Some patients may prefer a heat pack. Suggest to the patient to take pain relief at home, such as paracetamol or ibuprofen. Your facility may be able to provide this or propose to the patient to purchase this. Some patients may need several pain reduction strategies, whilst others may prefer to just get jabbed and go with a minimum of fuss. Keep in mind that the injections can become more tolerable to the patient over time, in particular when the very first injections have been as pain and stress-free as possible. Here are other strategies for you as the clinician or your healthcare facility to consider to reduce the stress and inconvenience experienced by patients. Feeling cared for and nurtured and having a sense of belonging to a health service is very important to ensure people continue to return to the health service regularly. Feeling valued may even be more significant than feeling no pain. Accommodating the parent or caregivers may also have a significant positive impact on the relationship between the patient and the health service. A good care plan can be used to document the patient's preference in relation to pain relief and chosen injection site. This ensures that the patient does not need to explain this at each visit and may give them a sense of being in control. Moving patients quickly and respectively through the injection procedure will avoid anxious waiting times, provide
privacy. Having to bear a part of your body to a stranger may be an uncomfortable or culturally sensitive issue. Health staff of the same gender as the patient may make the patient feel more comfortable. Patients may prefer the injection to be given by the same person at each visit. Where a pharmacy prescription is required, ensure Bicillin is prescribed and issued as a complete pack of 10 pre-filled syringes. This ensures that trips to the pharmacy by the patient are kept to a minimum. Store the patient's unused Bicillin syringes in the health facility's fridge. Taking this home to store in the family's fridge can result the solution to reach incorrect temperatures. And storing sharps in a household where young children are likely to visit is not advisable. A dedicated Bicillin day so ARF patients can all come at the same time, aids the facility with recall and provides regularity and peer support for the patient. It is essential to understand the reasons why some patients may have troubles attending the clinic regularly. If this is related to personal transport, can either your facility or another organisation help provide this transport? If it is related to distance, can an outreach service be provided to the patient? It is important that healthcare facilities have an active recall system. Patients should be recalled from the end of the 3rd week after their previous injection, so that their next injection is given no more than 4 weeks or 28 days later. A Bicillin chart can assist with recall and keeping track of the Bicillin prophylaxis given. Discuss reminder methods with the patient. For example, when patients have access to a mobile phone, the calendar or alarm function could be set up as a reminder. Injection reminder cards could be completed by the nurse and held by the patients. And last but certainly not least, education. It can be said that education is a patient's right and a healthcare provider's responsibility. It is very important that people with ARF and RHD receive regular, appropriate education about the importance of the disease and treatment. They need to understand that this disease is chronic and serious. You can ask the patient what they understand already and then build on that knowledge. It is also important to involve the patient's family and support group in education so that ongoing support is available outside the health service.
Just to recap, acute rheumatic fever can result in damage to the heart valves, which can lead to the need for surgery and possibly to premature death. Reoccurrences of rheumatic fever can be prevented by antibiotic prophylaxis in the form of intramuscular Bicillin injections, but only if this is given with the intervals of no more than 28 days. and for a period of at least 10 years. By keeping pain, stress, and inconvenience to a minimum, and by building a good relationship with patients and their families, we have the highest chance of the successful uptake of this lengthy but important treatment. For more information for health staff and for patients and their support, visit the RHD Australia website. Education modules are available within the Professional Development section, completion of which will entitle you to receive a certificate for evidence of continuing professional development.